And so you're gonna inspect the outside of the ear. You make sure you look at the back of the ear as well. And so when you inspect the outside, what do you say?
No lesions or discoloration, non-tender bilaterally.
Yeah, so you can help read the.
It's inspecting it.
Yeah. Okay. So for the next part of the ear exam, you actually need the otoscope. So you guys can use the wireless ones or you can use the wired ones. If you use the wired ones, we'll kind of show you some techniques to try to keep the wire out of the way. That's the hardest part. The big thing with the otoscope in particular is you've got to have 2 points of contact for this one. What I'm gonna have you do is go and lift your arm up and then bring your arm down. And so by doing that, I've stretched it. Now I have a lot more room to move around with this thing. So one of your points of contact is gonna be grabbing the pinna, or like the actual like ear part, and then you're gonna wanna kind of pull it up into the back. And what that does is it helps to straighten out the extra auditory canal. So that's one point. And then your other point is gonna be where you're touching somewhere on kind of the side of his face. We want you to be above the level of the TMJ joint itself, because if you're down on the mandible, if he starts to move his mouth, then your point of contact is moving and your bracing is not really as effective. So stay above the TMJ if you can. You'll have to figure out which way you like to hold the otoscope. So some folks like to hold it like this, and then they'll use like a finger here to brace. Some folks like to hold it like this, and they'll use a finger here on the temple to brace. So one point of contact is your hand that doesn't have the otoscope, and you're pulling the ear back. The other one is a finger that is resting on the temple, and then you come in and then you take a look. And so initially you're gonna evaluate the extra auditory canal, so that's just all the spaces that are leading up to the tympanic membrane. And so the best way to insert the speculum into the ear is to get yourself prepared. So pull the ear back, rest your finger, so you're not back here trying to fit the speculum into the canal. And then you can kind of use the speculum to open up the ear a little bit more, and then go in so that you're not driving it all the way to the back of their ear. Okay, so what do I say for the extra auditory canal?
No swelling, obstruction, or redness.
And then I'll show you on this side. You can use the same eye and the same hand if you want to. It's sometimes a little bit easier to switch hands and switch eyes based on which side you're on. So again, go ahead and raise your arm up for me, and we're gonna back down. And so it's on stretch, so I have lots of room here. So one hand is back here, straightening out the ear. I put my pinky on his temple, so I'm above the TMJ. I'm really close to the extra auditory canal. I'm opening it up, and then I'm going in and I'm looking. Okay, and so when I go in and I look, similar to the eye exam, this is where I can actually say all the words for the TM. So go ahead and.
TMs are pearly gray and translucent. Light reflex is anterior inferior quadrants. Pars tensa and pars flaccida umbo. Handle of malleus visualized and undistorted. No fluid behind TM.
Okay. And then while you're still here, what you'll do is you'll instruct the patient, go ahead and plug your nose. And then when I ask you to, I want you to breathe out. Go ahead and breathe out and relax. And so what you're looking for there is you'll see the actual tympanic membrane bulge out, right? So the back of your throat, your nose, and your ear are all connected. And so if you've closed your mouth, you close your nose, and you blow out, then the tympanic membrane is actually going to push because that pressure has only one place to go. Okay, relax.
TM's mobile.
So that's everything for that part of the otoscope.
So as we're doing that, as soon as we're looking inside the ear, can we just
start
rattle it off? So like no swelling, obstruction, or redness. TMs are pearly gray. All of that, just like eyes.
Yeah. Medicine. Yeah. Okay, so the next is hearing. And so this is the whisper test. What you're trying to do is you're trying to get like an apples to apples comparison on each ear. So put a hand out on their shoulder, so it's going to be the same distance when you're on their left side and the right side. And then you're going to say some sort of word or phrase.
We said cranial nerve number 8.
Cranial nerve is fine. Generally, you say like you want to have the same number of syllables on each side. So if you want to do like baseball, so you whisper baseball. I guess I have to give them a sorry. So go ahead. I'm going to say a word. I'm going to whisper a word. I want you to repeat it back to me when you hear it. Cover your left ear. Baseball. Okay. And then you go around to the other side. Go ahead and cover the other ear.
Volleyball.
Okay. So the reason that you have your arm out is so that's the same distance, right? If I'm up here and I whisper, and I'm way back there and I whisper, and there's a difference, it's probably because it's the distance. It doesn't necessarily mean that it's hearing issues. Okay? So what do we say after that one?
Cranial nerve.
Okay. So next is your Weber and your Rene. So Weber is going to be where you use the tuning fork and you're going to place it centrally. So you have to use the tuning fork that doesn't have the little doodads on the top of it, so it's a little higher frequency. So you're going to strike the tuning fork, so it's vibrating, and then you want to place it kind of dead center. Do you hear that in both ears?
Yes.
Okay. Is it louder in one ear or the other?
No.
So that's the Weber. So you're trying to see if the sound lateralizes to one side or the other. And then the Rene that comes along with it is you strike the tuning fork again, and you're going to place it right here on the mastoid process. Do you hear that?
Yes.
Tell me when you stop hearing it. And so it sometimes goes away really super quickly. Sometimes you have to like deaden it. You bring it to the front. Do you hear that?
Yes.
And then you confirm that you can hear it as well. That way they're not lying to you.
So Weber is equal bilaterally. Rene is AC greater than BC bilaterally.
And so you do the Rene on both sides. Weber is just one because it's the central. Okay, so that is all of the ears. So next is the nose. You're going to want to use a different speculum here when you finally get to that. So the first part is inspecting. So you're going to look at the nose and see if there's any.
Nose is midline and without lesions or tenderness.
Perfect. And so when you're palpating the nose, you're going to palpate along the midline. So starting up at the nasal bone and then along the cartilage. And you're going to want to palpate along the nasal bone laterally as well. So palpate down the midline and then along the nasal bone there. And then that's where you say.
Nose is midline and without lesions or tenderness.
Okay, perfect. Thank you. All right, so the next part is palpating and percussing the sinuses. So this is where you guys will start off being very gentle with each other. But if you're gentle, you're not really going to get a very good exam. So you have to actually put forth a little bit of pressure here. So the two sets of sinuses that we can touch are our frontal and then our maxillary, all right? So frontal sinuses, the best way to actually cause the pressure sensation to happen is you just are gonna get right up here underneath the orbital ridge and just press firmly. And for the maxillary, remember, it's not out here on the like zygomatic arch, it's more centrally. You're gonna press here, kind of maybe a little bit more inferior to where you were with the lacrimal gland. So that's the palpation part of it. And then for the percussion, you can just take your fingers like this, and you're gonna go.
Sounds hollow.
It is hollow. Have you talked to him
Like
before?
extra.
Right, so, what a geek. So you're gonna percuss both sides frontal and both sides maxillary.
No maxillary or frontal tenderness.
Okay. So the next one is going to be patency of the nares. So go ahead and plug one nose or one nostril and then breathe in, and then plug the other nostril and breathe in, right? And you're going to look to see if like the little alar fold kind of comes in, all right?
Nasal passageways are patent.
So next is testing cranial nerve 1, which is odor discrimination. So you're going to have two different smells. And so let's say that these are my smells. And make sure that they're not like noxious things, right? So if it's like really, if it's smelling salts, it's going to cause like irritation to like the actual skin tissue, and so cranial nerve 5 is going to interpret that. But if it's like coffee grinds and Dove soap or something like that, it should be good. All right. So go ahead and close one nostril, and then close your eyes, and then go ahead and breathe in. Okay. And then with your eyes closed, close the other nostril, and breathe in. Right? Did you just smell both of those?
Yes.
Were they the same or different?
Different.
Okay, and so the big piece is the same or different that people miss a lot of times.
Cranial nerve 1 intact.
Okay. And then we can move on to the otoscope itself. So again, anytime that you're using the ophthalmoscope or the otoscope, you have to have 2 points of contact with your patient. With the otoscope, it's a bigger deal because you have a speculum that you're actually going into like an orifice, so you don't want to drive it too deep. Go ahead and lift your arm up for me and bring it back down and hold it. So again, this just gives me a lot more room to work with. So there are different ways that different people do this. One of the ways that a lot of people find is easiest is if you place your hand on their jaw. You don't have to like manhandle them like you're a bear. But then you can hold the otoscope in your hand. And so if I'm gonna look in his right nostril, I might use my right hand. That way I'm a little off center from him. And so I can take my otoscope, use my fingers, and they're resting against my hand, and then my hand is on his jaw, and then the speculum goes into his nose just a little bit, and then you're gonna bring your face in, and then you're gonna look, and then you would do the same thing on the other side. So this is one way of doing it, and this is probably like the easiest way that folks do okay with. The other way that you can try to do it, if you like to, is if you hold the otoscope upside down, and then you put a finger on their cheek, and then you can take your other hand and bring their nose up just a little bit, and then you can look in, and then you can do the same thing over here. And so it's always easiest before you go in either the ear or the nose to rest your finger on your point of contact, and then go into the spot that you're trying to look. Okay.
Mucosa is pink and moist without lesions. Septum is without perforations. Unable to visualize superior turbinate. Middle and inferior turbinates without edema. Without discharge, edema, exudates, or polyps.
Okay. So that's everything that requires the otoscope. So ears and nose. Any questions or things that you guys want to look at?